Well, good evening, everyone. Welcome to our webinar tonight. It's called the Clinical Application of Multimodal Imaging. My name is Tim Cole. I'm the Clinical Affairs Manager for Heidelberg Engineering. I'm joined in the background this evening by Emily Malbon. She's head of the UK Academy, and both Emily and I will be shortly vanishing from your screen and hidden away in the background answering your questions this evening. So it's really my great pleasure to introduce you this evening to Roberto. Roberto is a very good friend of ours and has worked with Heidelberg on a few projects for many years now, actually 8 years in total. And this evening is really Roberto's evening. He's going to go through a lot of his own cases and how he uses multimodal imaging in his practice as an ophthalmologist in Valencia in Spain. And just so you know, the great thing about this evening is normally, outside of this very strange lockdown time we find ourselves in, Roberto helps us with our non-invasive vascular imaging course, which we put on a couple of times a year in Heidelberg. Roberto is one of the main speakers who's been on that with us. So the great thing about this evening is you're going to get a taste of Roberto's input to that really successful, fantastic course that we run in our head office in Hemel Hempstead. I now leave you in Roberto's good hands, and I will pop up at the end of the webinar and in our little breaks just to answer the questions and read those out to Roberto. So thank you very much, Roberto. Take it away.
Thank you. Thank you very much, Tim. But all the credit of all these educational activities is absolutely yours. I mean, Heidelberg Engineering UK is extremely committed to education and to help all of us to better understand pathology and to better diagnose our patients. So I, as I always say, you are an example for everybody, a mirror to look at. And I fondly appreciate that, as you mentioned, even though it has been quite a bunch of years, you still have me and give me the opportunity to give these little webinars. For example, today, the role of multimodal imaging, the clinical application of multimodal imaging in our routine practice. These are my financial disclosures, which unfortunately are not relevant, and I wish they were, but it's not the case. And what about multimodal imaging? Please don't panic. We are not going to go into detail in all these imaging modalities. It's just to show how multimodality has evolved through the last decade, the last 2 decades, with a lot of extremely relevant information about structure and even function in patients with retinal diseases. So as far as we better understand and make our diagnosis for them, we can provide an accurate treatment, and that's key to obtain significant positive outcomes for our patients. So I have summarized in 3 little parts today's webinar. First of all, we will talk about age-related macular degeneration, then we will move to diabetic retinopathy, and then we will finally move to posterior uveitis. So why begin with AMD? Obviously, this is the most frequent case in our daily practice. And as we know, age-related macular degeneration is a myriad of signs that we're better understanding thanks to multimodal imaging. And I would like to show you this case. So how would you diagnose this patient? There's no atrophy. There is no neovascularization. So what's the stage for this case? Because here you can barely see those dots located in the superior part of the macula. But take a look at the infrared reflectance image. A huge and widespread involvement of the entire macula by subretinal drusenoid deposits or reticular pseudodrusene. So in my hands, in my experience, to obtain an infrared reflectance image is key in patients with age-related macular degeneration. Let me give you another example. So what what can we see here in this lady? We see soft, large drusen. Again, we see no atrophy, and we see no neovascularization, apparently. But you see all those tiny dots. With a multispectral image, you can perfectly delineate, and it really highlights a lot the presence of these particular deposits, this particular type of drusen, which are at highest risk to progression to a bad advanced stage of AMD. So it's extremely relevant to identify the presence of these subretinal drusenoid deposits. And what about atrophy? Okay, we all know that autofluorescence is the gold standard technique to image atrophy, geographic atrophy in patients with AMD. But what about the fovea? Remember that blue wavelength autofluorescence shows always the fovea hypoautofluorescence, given the absorption of the macular pigment to this particular wavelength. However, multispectral image doesn't show that behavior, so we can perfectly delineate and identify the foveal involvement of sparring, not in a case easy like this, but for example, in a case like this. Both eyes, charming woman, obviously geographic atrophy. So my question is, right eye, left eye, which one of them is involved? The fovea is involved with this atrophy. Take a look. I will help you out with the multicolor image. So it's clear that the left eye has foveal sparring of this geographic atrophy. And surprisingly, there is a foveal remnant inside the geographic atrophy, also in the right eye. So infrared reflectance and multispectral image is extremely helpful to identify the foveal preservation in patients with geographic atrophy. As we said earlier, given that with blue light autofluorescence, the fovea always appear dark. So the closer the atrophy to the fovea, the more challenging to identify the preservation or not of the fovea. Here you can see an example of progression of atrophy with autofluorescence. But again, we shall never forget about infrared reflectance, because as you can see, the information that this imaging technique provides is extremely reliable and overlaps the information provided by autofluorescence. But for this, we don't need to dilate the patient. We don't need to make that exposure that for some patients is very uncomfortable. And every time we obtain an OCT image, also we have by its side this image. So we can analyze this atrophy with every appointment of the follow-up very easily. Final example about atrophy. You can see here the autofluorescence image with a large patch nasal to the fovea, a small patch temporal to the fovea. So it's the fovea involved right here, yes or no? Because you can see the fovea hypoautofluorescent, but it should be the nature of the fovea. Infrared reflectance, again, is extremely helpful to differentiate that. And also through the follow-up, here you can see how the fovea is involved, but the autofluorescence is still some way tricky to interpret. So never forget infrared reflectance to identify subretinal drusenoid deposits, to monitor progression of the atrophy, and to make sure that the fovea is not involved in such cases. Here you can see at the beginning widespread involvement of the macula with subretinal drusenoid deposits, with development of geographic atrophy, and the progression with the infrared reflectance image of that macular atrophy, extensive macular atrophy. No autofluorescence shown, just the infrared reflectance image is fair enough to provide information about the follow-up and the behavior of that atrophy. Another deposit with high risk of progression to advanced disease is this one. You can see the typical hyperautofluorescent lesion corresponding to that hyperreflectant image deposit subfovally, which typically consists of a shell provided by the photoreceptors on top and the RPE underlying it. Multispectral image shows that reddish appearance where the RPE is becoming hyperplastic. Surrounding that reddish area, you can see the vitelliform appearance of the lesion. But whenever we have any doubt about that, we can use the blue channel, because remember that the blue reflectance or the blue color photograph will make disappear that vitelliform lesion. And this behavior is typical for acquired vitelliform lesions. And remember that these patients eventually may develop first outer retinal atrophy and after that RPE atrophy, following a catch-up phenomenon of abrupt resorption of the material by the RPE. This happens about in half of patients after 5 years of follow-up. So definitely, we need to identify acquired vitelliform lesions to provide an accurate prognostic estimation to our patients. But on the other hand, don't forget that for those AMD cases non-responding to anti-VEGF intravitreal therapies, almost 50% of them correspond to misdiagnosis. So almost half of patients considered non-responders to anti-VEGF therapy is not the problem of treatment, is a problem of the clinician missing the diagnosis. So we need to identify this type of lesions. And eventually also we may find partial resorption of the vitelliform material within the lesion. And for these cases, OCTA is extremely useful. You need to look at the structural OCT image with the flow overlay to make sure that there is no flow signed at all. Thus, meaning that there is no neovascular lesion complicating this case of acquired vitelliform lesion with partial resorption of the material. There is no exudation. In a similar way, the same OCTA image is extremely useful also for drusenoid pigment epithelial detachments, because it's another frequent misdiagnosis of neovascular AMD. These are drusenoid pigment epithelial detachments. You can see the structural OCT and again the flow overlay with no evidence of neovascular tissue, with no evidence of flow within that PED. You see a lot of intraretinal pigment migration, which is a risk factor for progression to atrophy. Remember that also pigment epithelial detachments eventually may collapse and induce outer retinal and retinal pigment epithelium atrophy. But in this case, the OCTA image is not that good when we are using unfast reconstruction. The perfect way to look at these images is with the structural OCT with the flow overlay. Correct? No evidence of flow, so no evidence of neovascularization, no need at all to perform any kind of intravitreal treatment. Moving to neovascular AMD, as you all know, phenotyping with a structural OCT neovascular lesions is essential in order to provide patients a very accurate prognosis and to understand the need for treatments and the risk of atrophy. So to begin with, we have lesions below the RPE corresponding to type 1 neovascular lesions, type 1 macular neovascularization. and lesions on top of the RPE, corresponding to type 2 lesions, type 2 macular neovascularization. This is not a random classification. This is based on the histopathologic evidence published years ago by Donald Guest and Hans Gross-Niklaus, where you can see that they found lesions under the RPE and lesions eroding the RPE, growing within the subretinal space. Type 1 and type 2 lesions. And those images correspond beautifully and very nicely with the structural Lct information that we can achieve in every single patient coming to our clinics. In addition, we know that there are peculiar cases with those aneurysmal dilations under the RPE between Bruch's membrane and the RPE, with large serohemorrhagic pigment epithelial detachments. And this is the typical features of the formerly called polypoidal choroidal vasculopathy, PCV, nowadays more accepted, the term aneurysmal type 1 macular neovascularization, because there are not polyps in the vessel, these are aneurysms, so it's a much more accurate name. What do we need in such cases? Is that enough to make the diagnosis? I don't think so. I think that's more than enough to presume the diagnosis, but you need ICG to illustrate and to identify those aneurysmal dilations very nicely in the video angiography, very nicely shown with ICG. And what about OCTA? As you know, OCTA is not that accurate to identify the aneurysms, but it can provide a lot of information about the branching vascular network underlying those aneurysmal dilations. Here you can see another example. The typical late plaque on ICG corresponding with the branching vascular network, and in this case, OCTA is able to show the aneurysmal dilation temporal to the fovea in the right eye, and also right here in the left eye, but showing all together with this the beautiful branching vascular network responsible for the plaque lesion seen in the late phase ICG. So we have aneurysmal type 1 macular neovascularization as a subtype of neovascular AMD. Let's move back to the phenotyping with the structural Lct. And I think we all agree that this is a type 2 lesion growing within the subretinal space on top of the RPE. So we administer the first intravitreal anti-VEGF treatment, and we obtain this response. What has changed here? As you can see, the fibrovascular lesion was growing within the subretinal space on top of the RPE, and suddenly the RPE is enveloping that lesion. So how do we call that? We call that a regression pattern of a type 2 lesion into a type 1 lesion. This is not infrequent in patients with AMD. Type 2 macular neovascularization represents about 10% of all the neovascular lesions in patients with AMD. But focusing on type 2 macular neovascularization in patients with AMD, more than half of them can eventually evolve into a type 1 pattern. And what does that mean? Type 2 lesions lead to subretinal fibrosis, autoretinal atrophy, and significant vision loss. However, type 1 lesions are correlated with a very good visual preservation through the long term. So it makes a lot of sense for our patients. Here you can see another example. Subretinal hyperreflective material corresponding to a type 2 lesion and the conversion to a type 1 lesion. And with further treatments, it remains like that through the follow-up. So it's something to take into account it's very important when you find a type 2 lesion to monitor the early change and conversion from a type 2 to a type 1 lesion, because this changes completely the prognosis of that particular case. And also, we cannot allow this neovascular lesion to grow again into the subretinal space. Finally, we are missing the third neovascular subtype, the third phenotype, macular neovascularization type 3, corresponding to retinal angiomatous proliferation, perfectly illustrated here with those lipid exudates, microhemorrhages in the parafoveal area, and the typical hotspot in the fluorescein angiography. Is OCTA helpful in such cases? Well, let's look at the typical appearance in the structural OCT. You can see the funnel-shaped configuration of the inner retina looking downwards to the RPE. That's the typical configuration of a type 3 lesion. But what is that column, that vertical column of that configuration representing? Here you can see an OCTA. Again, the en-face reconstruction, superficial, deep plexus, not that helpful. But let's take a look at the structural OCT with the flow overlay. You can identify that vertical sign of flow, absolutely typical of type 3 macular neovascularization. So OCTA, whenever we have any doubt about the presence of a type 3 lesion, is extremely helpful because you can identify in all cases this vertical column of flow coincident with that hyperreflective column that we were seeing, the structural OCT right here. So the funnel shape configuration and that vertical vascular area. And what about subretinal hyperreflective material like this one? As you can see here, this charming lady is showing subretinal fluid and also hyperreflective subretinal material. Is there a neovascular tissue there? Is that exudation? Is that fibrosis? Well, easy. We go for the OCTA image, we scroll all of it with the structural information with flow overlay, and you will see that the subretinal hyperreflective material is not showing any flow sign at all. So we can conclude that this is exudation. There is no neovascular lesion there, there is no type 2 component in such case, and the risk for subretinal fibrosis is less than expected. Another example. This lady, chronic exudation, type 1 lesion, apparent subretinal fibrosis, we cannot tell for sure. That's a subretinal hyperreflective material again. Once again, OCTA, structural information, so we can see flow within the type 1 lesion under the RPE, and then we're scrolling towards the subretinal hyperreflective material where we can identify flow. So this is a mixed lesion, type 1 under the RPE and type 2 on top of the RPE with chronic exudation, and you can see also outer retinal tubulation developed under the neurosensory retina, right? Final point, OCTA in AMD. I have been worldwide, I would say, criticized because I don't trust that much OCTA. I'm extremely in love with the structural OCT, but I have certain doubts in some cases with the role that OCTA can play. But look at this. nobody can tell for sure what this is. We can only say this is a shallow, irregular RPE elevation, SIRE, SIRE. So what shows the OCTA here? It shows what has recently been described as non-exudative neovascular AMD. No history of exudation, no evidence of exudation, but a clear neovascular lesion growing in a patient with intermediate AMD. And we need to identify this because these patients are at much higher risk to develop exudation in the short term. Some other examples. What we can see here, again, a shallow, irregular IP elevation. That OCTA shows beautifully the configuration of that neovascular lesion, that non-exudative neovascular lesion. Once again, shallow, irregular RP elevation, a large neovascular lesion with no exudation, non-exudative macular neovascularization. So, in summary, we have 1, 2, and 3 main phenotypes of macular neovascularization in patients with AMD, with neovascular AMD. Obviously, we need to add to this the mixed lesions whenever 2 or more of these phenotypes are coincident in one particular case. We have learned that type 2 lesions may eventually convert into type 1 lesions while healing after the initial anti-VEGF treatment. And we shouldn't forget about aneurysmal type 1 macular neovascularization and the need of ICGA for the accurate diagnosis of this. So this is the end of the first part, which is also a clear example of multimodality, mandatory to better understand what's going on in the macula and retina of patients with diabetes. A few practical considerations. There is an ongoing discussion about what is better, fluorescein angiography or OCTA, to assess the status of the foveal vascular zone, which is key in the visual prognosis of patients. First thing to notice, this is obvious, but whenever you have intraretinal cysts, the fovea, don't rely much on that fast reconstruction in the superficial and deep vascular plexi. If you look closely to the image, you can identify the cysts in the OCTA fast reconstruction. So they are leading to a misalignment and segmentation artifacts because of the distortion of the normal retinal anatomy. So don't be confident whenever you have intraretinal cysts assessing the foveal vascular zone. If you have no macular edema, if you have no cysts, then the information provided by the OCTA is by far better than fluorescein angiography, much more precise, deep plexus and superficial plexus. But another recurrent question is, okay, I have my image right here, so what should I look at, right? So there are 4 things, very easy. Circularity and symmetry of the foveal vascular zone. If you lose circularity or symmetry, then you have a diseased foveal vascular zone. And also, you can look for vascular loops and decreased vascular density, which are 2 hallmark features of not only diabetic retinopathy, but any kind of retinal vascular disorder. So these are the 4 things that we need to look at in our AMFAS OCTA reconstruction of diabetic retinopathy. Okay, Robert, stop for a second, because you said that the AMFAS reconstruction in AMD was not that useful, and now you are only showing AMFAS images of the OCTA. Yeah, I always do it that way. For patients with vascular disease, the OCTA AMFAS reconstruction is extremely useful because the segmentation in most cases is perfect and it allows you to take a look at all these signs. However, in AMD, it's not the case, and the segmentation is not always that good. That's the reason why I was showing structural OCT with flow overlay before, and I am showing fast OCTs now. Another example, that's the reference for the OCT shown on top of the fluorescein angiography. And take a look, superficial plexus and the fellow eye, superficial and deep vascular plexi. So, okay, I have my image, what should I look for? Again, loss of foveal vascular zone circularity, which is the case, loss of symmetry, which is the case, decreased retinal vascular density, which is the case, and vascular loops, which are the case. So you have all four signs proving that the visual performance of this gentleman should not be good. Circularity, symmetry of the foveal vascular zone, vascular loops around it, decreased vascular density around it. Easy. But we don't want to forget about neovascularization in patients with retinal vascular diseases. Is there any role for OCTA in such cases? Obviously. We shouldn't forget also about the macular slab that you all have on your OCTA device. Use it. It's just a click away to obtain these beautiful images of the retinal neovascularization present in this case. Another example, you see the multicolor image, fluorescein angiography image, both eyes, superficial plexus, horrible right eye, deep plexus, and we can use the OCTA not only in the macula but elsewhere. For example, here, showing very nicely the retinal neovascularization and the response to anti-VEGF therapies or panretinal photocoagulation. So you can show patients very clearly, look, this was the appearance at baseline, and this is how your neovascularization is looking now, easily. Also, remember that whenever you have an OCTA image, you also have a retinal thickness map. So, in patients with the diabetic retinopathy, or again, any kind of retinal vascular disease, you may find these thinning areas represented here in blue. Why is that? Because of ischemia. Inner retinal layers ischemic lead to atrophy, and this is why the retina is appearing thin. So right here, you will evidence for sure a decreased vascular density. So there is a very nice correspondence of both indirect signs that you can look for if your suspicion is the presence of ischemia. And with your OCTA, you can definitely show that. Another example, look at the retinal thickness map. And anybody can tell me at this point, where do you expect to find decreased vascular density? Obviously, right eye, right here. Superficial plexus and deep plexus. But again, it's just a click away to go for the vitreoretinal slab showing this beautiful retinal neovascularization. This is another example of the superficial deep plexus with this vitreomacular slab and fast representation. Does it look like neovascularization? Does it really look like vessels? You will find many times this appearance. When will you find that? Whenever the posterior hyaloid is partially detached. Because remember that OCTA is not showing vessels. It is showing flow, movement. And the posterior hyaloid partially attached to the optic nerve head has motion. So OCTA is showing motion of the posterior hyaloid. So this is not an artifact, but something to take into account whenever you are considering the vitreomacular interface with the OCTA. This is not neovascularization. And look at the deep plexus en-face image down there. Do you consider that a possible neovascularization, choroidal neovascularization, macular neovascularization, complicating this case of diabetic retinopathy? Actually not. This image corresponds to high density content of intraretinal cysts. And again, it is showing movement. High density content of intraretinal cyst shows this behavior right here, which has been described as suspended scattering particles in motion. I am not smart enough to explain this. It's some kind of Brownian movement, and it corresponds to a high density content of an intraretinal cyst, localized like this case, or more widespread. So this is very brief. Posterior uveitis. So what do we see here in this beautiful case from Dr. Larry Janesi, New York? We see the typical appearance of a patient with mutes. You see spots and dots. Right here with the granular appearance of the macula, larger spots, smaller dots. The typical appearance of that wreath-like pattern in fluorescent angiography. You can already make the diagnosis of mute, but you will never have the information of the choriocapillaries involvement in these patients if you don't go for an ICGA. I'm sure you didn't expect that appearance. And what's the typical appearance of mutes in a structural OCT? The one you are seeing here. The hyperreflective material from the RPE eroding the outer retinal layers. It can show up like this with a vertical column or a more mound-shaped deposit. But altogether with this, the evanescence of those spots and dots, structural OCT will recover. That's typical for mutes. But remember the appearance at the beginning. Very, very few cases or diagnoses can induce this beautiful structural OCT image. Posterior uveitis in patients with myopia. Okay, these color photographs are from a highly myopic patients. This assumption doesn't really, it's not equivalent for a Nobel Prize. It's evident. But look at the images. This is not just high myopia. You see the typical patchy atrophy, focal chororetinal atrophy. And you can also see those dots, typical for multifocal choroiditis. Not the same thing. And the prognosis is completely different because up to 1/3 of patients with multifocal choroiditis may eventually develop inflammatory choroidal neovascularization, which doesn't behave as myopic CNV does. So we need to identify multifocal choroiditis in patients with high myopia. You can see here the typical autofluorescence of that patchy atrophy of myopic eyes. It's different. Look at those spots with that curvilinear appearance at some point, and that's diagnostic and almost pathognomonic of multifocal choroiditis. Here is an example of an acute multifocal choroiditis case showing early hyperfluorescence with late staining. And again, structural OCT makes a difference. Look at those very tiny disruptions of the RPE with the borders looking all the way up. That's the way we can find inflammation in patients with multifocal choroiditis. That's the typical OCT. High density subretinal fluid, focal erosion of the RPE, and the borders of that disruption looking all the way up. Inflammation and neovascularization are both very relevant for patients with multifocal choroiditis in terms to assess the prognosis, but many times they are together in the same patient. So even with fluorescein angiography, ICT, it's very difficult to make sure that we are facing a case with inflammatory CMV or only inflammation. But for these cases, OCT is absolutely relevant because it will highlight the presence of neovessels. So again, OCTA is key in posterior uveitis in order to make the distinction between neovascularization and inflammation. Here you can see another example. Highly myopic, young, beautiful woman, subretinal exudation, high density. You can see it here. The typical inflammatory signs with that hypertransmission to the choroid, and at the level of the fovea, we see that high density material. So is that a neovascular lesion somewhere in that scan? Can you identify that? It's only inflammation. Are you sure about that? I'm sure that now you are sure about that. OCTA in patients with posterior uveitis, even when they are highly myopes, can show perfectly well inflammatory CMV complicating a case of multifocal choroiditis like this. And as I was expecting a few questions, I didn't want to move further. I didn't want to take more time from you. I would like to thank you very much for the opportunity to be here. I would fondly thank all the people joining this webinar, and I hope you find this useful. So I'm happy to answer any questions, if I may, Tim. And
thank you very much, Roberto. As always, a really great presentation, and I think you walk through OCTA in such a great way. You make it really easy to understand, and particularly I always try and replicate your explanation because you're a big fan of the cross-sectional OCTA flow overlay, aren't you? And I've always brought that into my own teaching when I'm teaching people. Okay, so we're at the actual end of our hour now. So if any of you need to go, that's absolutely fine. Before you do, just remember that on the GoToWebinar control panel, there's actually a handout this evening with some paperwork, some information about the Spectralis. If you need any more information like that, you can also visit the website where you can get anything you need to know about OCTA, and eventually you'll find recordings of this webinar and our other ones if you want to watch those again, but also to keep an eye on them for some of our future webinars that we've got coming along soon. And a lot of those we're actually in the season now, towards the end of this last year, we've chosen to stay on the subject of OCTA, so you're going to see a few more about this subject to come. For those of you that would like to stay, and I can see there's still about 240 people still here. I didn't tell you the number, Roberto. So, I think we'll answer a few questions for those of you that would like to stay. I've flagged a few that came in here just towards the end. We've had a few actually about the slab choices you make, Roberto, when you're looking at your OCTAs. So I know you mentioned a few of the predetermined anatomical slabs we have in the software. Is there like a quick way that you dive in when you're looking at, say, your AMD patients? Do you jump to choriocapillaris segmentation, for example, and move that up and down? Or do you have like a custom slab tool in your software? How do you use it?
I like to do it exactly the way you said. So I go for a choriocapillaris slab and I move it all the way up.
Right.
To look for evidence of neovascularization. But again, I very rarely use the en face reconstruction in patients with AMD. I like much more to look at the structural Lct with flow overlay, because the flow overlay will show me where the neovascularization is present. And to my knowledge, the fast reconstruction is not yet able to show any hint about activity, progression, growth. Besides, there are a bunch of publications talking about capillary frames, about the precise configuration of the network, etc. But the way I use OCTA for AMD is choroid capillaries move a little bit up and down, looking for the width of the neovascularization and the configuration as it is apparent on the fast image. But then I immediately move to the structural OCT with flow overlay.
Yeah, actually that leads on really nicely into another question someone asked here, actually about that on-fast image. Someone has asked if you ever use it to give you an idea of the quality of the image. I know that on-fast sometimes can show you quite nicely if say for example, if you had a nystagmus patient or a patient with a very poor tear film. Do you ever use on-fast in that way to give you an idea of the quality of the OCTA flow information?
Yeah, I think that's the best way to look for those stripes, to look for those misalignments of the bezel. So it's extremely weird. I mean, honestly, while using the Spectralis platform, it's very difficult for me to find examples to illustrate this kind of situations.
I know you mean, like an actual black missing line of data.
It's extremely difficult to find that. But again, and by the way, I didn't mention the structural and fast image of the OCTA, which is always provided on the top left square in the OCTA, which is extremely relevant also. We don't talk about that, but it provides a lot of spatial information about structural changes happening. And in the same way that we use the fast reconstruction of OCTA, we can perfectly use the structural OCT fast reconstruction in the same way.
Yeah, I think in many ways the two do go hand in hand, don't they? Particularly when you're trying to understand what flows remaining in a disrupted, say, deep vascular plexus. You can often look across to the on-fast and say, oh, okay, I can understand the displacement of those vessels because I could see the exact on-fast perspective of where those fluid-filled cysts are within the retina. So yeah, I think the two do actually work very well together, don't they? Just to switch modalities for a second, someone just asking if you've got any tips about how to take a better quality autofluorescence image. They're asking if you dark adapt your patient or you do anything like bleaching before you do your autofluorescence imaging.
I don't bleach. But by the way, what do you understand by bleaching?
From what I understand, it means just keeping the blue light of the Spectralis on for a while to like saturate the area and before you capture your image rather than straight away building up the image. And I think some people do this particularly when they move from, say, going from a 30-degree lens to the 55, so that you don't have that ghost image of the actual shape of the 30-degree lens, you know. Maybe you could bleach the whole area with the 55 and wait for the art to build up before you capture an image. I think that's what that means.
Yeah, and I was asking you because you taught me that. So that's a very nice tip. So you flash for a while the patient with that blue light, and then you acquire the image. So that somehow enhances the quality and the contrast of the image that you are acquiring. Besides that, there are patients that are really photophobic and they don't tolerate well that blue light. There's no particular way to do it.
Yeah.
But again, if you need an autofluorescence image of those patients, you need Spectralis, because otherwise your information will never be valid. And again, a way to do it is, this is something obvious, but I always focus perfectly well the image very nicely with the infrared reflectance and the OCT to make sure that I am in the perfect position through the pupil and then I go for the autofluorescence by switching the imaging modality in the acquisition path. So there are times that I have seen people trying to focus with the autofluorescence already on to patients with that not very easy. Try to avoid that. Just make them easy the exposition by minimizing the time that they are in front of that light.
Yeah, I think it's really interesting how you use the OCT as a tool to get your positioning correct. So not only the focus and the infrared, but you know that you're at the right depth by using the OCT. That's a really, really great tip. That's great. Another question. Sorry, Roberto. Sorry.
That's part of my presbyopia problem also.
Okay, right. I see.
Is much easier,
You're not looking at the screen like this. Yeah, I see what you mean. That's again a good tip for anyone with presbyopia. Yeah, absolutely. Okay, I think I'll just probably ask this last question, and then we'll close the session for this evening. It's just about the pathway of using OCTA. Do you ever use lubrication drops with patients when you're going to do an OCTA? Because this is a tip I always give, but I'd like to hear if you ever do that yourself.
Again, Emily and Tim taught me this, and it makes a huge difference. Just to put an eye drop artificial tear to the surface before acquiring an OCTA image, it makes a huge difference. So I don't see any reason not to do it, because we all have artificial tears in our clinics, in our facilities. So it's something to use, and just try once, and you will understand what we mean. Yeah. Just try once. It's awesome.
Absolutely. I'm always trying to say it should almost be written on the side of the Spectralis or something. That it has to be written into the protocol, because you're absolutely right. It's like night and day, isn't it, when you use a drop and when you don't. And for those of you that maybe haven't used OCTA that much or not used drops before, I think the massive reason is because the extra tear film just provides a better signal of the OCT, but mainly as well for the patient's comfort. They don't blink as much, they can fixate longer, and yeah, it just really, really transforms OCTA. Okay, so we're going to have to end the session there, but thank you so much to all of you for hanging on, but of course, thank you so much to you, Roberto. Really wonderful session, and I look forward to doing more with you in the near future. Hopefully we'll see each other physically next time. Me, you and Emily get together at the next course. But yeah, all the rest of you guys, please send us all your questions. You can contact us through the website. If you've got anything specific for Roberto from his wonderful presentation this evening, just send emails to me and Emily, or get hold of us any way you can, and we'll answer those for you.
And make sure that you don't miss any of the webinars coming up. Tim told that you will not be losing your time. Absolutely, they are worth. Absolutely, make sure that you can join all of them, because these guys work amazingly well in favor of us. So don't miss the opportunity. And again, thank you all for your hard work. You know that Hemel-Hempstead is one of my favorite places in the world, and you guys are one of my favorite people in the world. So no need to thank me. I need to thank you for every opportunity that you give me. Thank you very much.
Thank you very much, Roberto. And good night, everyone. Thank you all.
Have a good night. Bye-bye.